So now we will discuss the type of acid-base disorders. There are primarily four types of acid-base disorder. So what is a metabolic alkalosis or a metabolic acidosis? Metabolic acidosis means the metabolic component, that is the bicarbonate, is decreasing. The bicarbonate metabolic component is decreasing and that causes metabolic acidosis. There is acidic nature. So compensate that there will be respiratory alkalosis. So for respiratory alkalosis, there should be hyperventilation and washing out of carbon dioxide leading to decreased PaCO2. Second is metabolic alkalosis. Metabolic alkalosis means the metabolic component, that is the bicarbonate, increases. Serum bicarbonate increases. So what did happen? For metabolic alkalosis, the compensatory mechanism is respiratory acidosis. For respiratory acidosis, we already told that we should retain the carbon dioxide. For that, we need hypoventilation and retaining of the carbon dioxide causing increased PaCO2 and compensating respiratory acidosis. Next is respiratory acidosis. In respiratory acidosis, the component of respiratory acidosis is CO2. The CO2 increases, that is acidosis, and the respiratory acidosis compensation is metabolic alkalosis. For metabolic alkalosis, there should be reabsorption of the bicarbonate from the proximal convoluted tubule, and that is done by the kidney. So there is compensation of respiratory acidosis by metabolic alkalosis. Next, respiratory alkalosis. Respiratory alkalosis means that the PCO2 is less. For a less PCO2, what we do is we will decrease the reabsorption of kidney and causing more release of bicarbonate from the kidney, causing acidosis, that is metabolic acidosis. The compensatory response is decreased bicarbonate. Next come the ROMS, that is a respiratory opposite metabolic same. That is a dictum that we will discuss later. In simple acid-base disorder, always primary change and compensation will move together. See, if pH decrease pH, the PCO2 and bicarbonate will be same direction. So this is a primary change in simple acid-base disorder. In primary respiratory disorder, change in pH with respect to carbon dioxide and bicarbonate in opposite direction. In metabolic disorder, the change in pH with respect to carbon dioxide and bicarbonate in same direction. We will discuss it in detail later. Now we will discuss about anion gap. What is anion gap? Anion gap means the difference between the unmeasured anions of the body and the unmeasured cations. The unmeasured ions are very less in blood compared to the measured ions. The measured ions are sodium, chloride, bicarbonate, which are in abundance. Unmeasured ions are potassium, calcium, magnesium, acetate, lactate, etc. To maintain body pH, total anion is equal to total cation. That is very important. So total anion means there is measured anion also plus unmeasured anion. They form total anion. For total cation, there is unmeasured cation plus measured cations. So finally the equation comes like this. Anion gap is unmeasured anion minus unmeasured cation, which is equal to measured cation minus measured anion. So finally the anion gap is equal to measured anion. So finally the anion gap is equal to measured cation minus measured anion, Mc minus Ma. So finally the anion gap is equal to measured cation. That is, the major cation is sodium minus the measured anions. The major anions are calcium and bicarbonate. So the normal anion gap is plus 12 millimoles per liter plus or minus 2. So it can be 10 to 14. So anion gap is equal to unmeasured anion minus unmeasured cation is equal to measured cation minus measured anion. So unmeasured anions. What are unmeasured anions? These are alphos. A for acetate, L for lactate, F for formate, O for oxalate, S for salicylate, S for sulfate and phosphate. Unmeasured cations are potassium, magnesium, calcium and lithium. Unmeasured anion, alphones, we should understand that acetate is formed in ketoacidosis, lactate is formed in lactic acidosis, formate is formed in methanol poisoning, oxalates is formed in ethylene glycol poisoning, salicylates are formed in salicylic acid poisoning, sulfate and phosphates are in renal failure, that is chronic renal failure. Remember that. So we will take an example of ketoacidosis. First we should understand that unmeasured anions minus unmeasured cation is equal to measured cation minus measured anion. So here in ketoacidosis, acetic acid forms into acetate and H plus. If know that acetate are unmeasured anions, just we told before. See in the previous slide, we just discussed that acetate are unmeasured anion which are formed in ketoacidosis. So unmeasured anions are increased. This unmeasured anions are increased. This H plus, what they do, they combine with bicarbonate, forming an acid that is H2CO3. So there is acidosis. So there is high anion gap. High anion gap, metabolic acidosis occurs. There is HAGMA. That is the cause of ketoacidosis and HAGMA in occurring. High anion gap metabolic acidosis. We just discussed ketoacidosis, salicylic acid overdose, ethylene glycol poisoning, lactic acidosis, methadone poisoning, renal failure, which lead to retention of sulfate and phosphate. Retention of sulfate and phosphate. Next comes normal anion gap metabolic acidosis. We are told that it is non-anion gap metabolic acidosis. So we are told that this is the equation for a anion gap. Here we should know that these are the anions, measurable anions. So what occur here is that the bicarbonate is lost. The bicarbonate is lost, so decreased bicarbonate. So in order to compensate for that decreased bicarbonate, the body will retain chloride. That is, chloride increases. So that means that is hyperchloride acidosis, hyperchloremic acidosis, we can say. That is chloride acidosis. So that is NAGMA or non-anion gap metabolic acidosis. The diarrhea will causes release of or loss of bicarbonate from the body, bicarbonate loss. Similarly, what happened in pancreatic fistula? The pancreatic fluids have lots of bicarbonate. When it occurs the fistula with any other organ, the bicarbonate is lost. Similarly, the antacids containing magnesium and aluminum. These magnesium and aluminum will combine with bicarbonate and they are excreted in the stools. So there is loss of bicarbonate and leading to metabolic acidosis, that is hyperchloride acidosis. Next comes the renal tubular acidosis, where the PCT cell prevent bicarbonate absorption. So the bicarbonate is lost from the body, similar to the renal tubular dysfunction. So there are drugs causing increased serum potassium, that is AC inhibitors, ARB, potassium sparing diuretics, and pentamides and trimethoprim. The serum potassium is, as we all know, it's a unmeasured or it's an ion, unmeasured anion. As we told here, they are unmeasured cations. Is metabolic alkalosis. Next one. There are also two types, that is chloride responsive metabolic alkalosis and second one is chloride unresponsive metabolic alkalosis. What the mechanism is here is losing H plus. So losing H plus along with chloride. So if chlorides are replenished, the metabolic alkalosis can be corrected in this case. So such chloride losing are H plus losing along with chlorides are vomiting, chloride losing diarrhea, diuretics like thiazide diuretics which block sodium chloride channel, and loop diuretics which block sodium potassium chloride channel. All these things. Next is sweat, that is loss, that is cystic fibrosis. Chloride responsive metabolic alkalosis. So chloride responsive metabolic alkalosis, this is because of reflex, this is because of aldosterone activation. Be it primary activation or reflex activation. So if it is a primary activation, there will be increased BP. It can be hyperaldosteronism. Like Cone syndrome. It can be Cushing syndrome or renin secreting tumor, or it can be Liddle syndrome. Liddle syndrome, what it does mean? It's INAC. That is activation of INAC channel leading to sodium absorption, potassium excretion. So in these cases, the BP will be higher. The primary sodium aldosterone activation, the BP will be higher. But in another case where the BP is normal or low, it's Bartter syndrome and Gentleman syndrome. What is Bartter syndrome and Gentleman syndrome? The Bartter syndrome represents a set of closely related autonomic recessive renal tubular disorder characterized by hypokalemia, hypochloremia, metabolic alkalosis, and hyperreninemic with normal blood pressure. The underlying renal abnormality is excessive urinary loss of sodium chloride and potassium. In Batter syndrome is that there is thick ascending leukophily, sodium potassium chloride reabsorption is a defect, calcium and magnesium is also lost. So it results in secondary renin activation, aldosterone activation, the DCT by reabsorbing sodium at expense of potassium and H plus, which means H plus and potassium is lost to reabsorb sodium in Bartter syndrome. So it means save sodium, lose H plus and potassium. I don't care. Save that sodium as soon as possible. That's the dictum or that the slogan in Bartter syndrome. Any any cost you save the sodium. In Gentleman syndrome, what does it happen in Gentleman syndrome? In Gentleman syndrome, it mimics the effect of thiazide diuretics. Similarly, we just saw thiazide diuretics which inhibit sodium and chloride, losing sodium and chloride. Okay, so for compensation, the body tries to retain the sodium by at the expense of H plus and K plus. So similarly, there will be hypokalemia and hypochloremia. Other causes are milk alkali syndrome and penicillin overdose. So primarily, the Bartter syndrome will mimic the loop diuretic effect, and the Gentleman syndrome will mimic the thiazide diuretic effect. Next comes the respiratory acidosis, retention of CO2 in the body, that is hypoventilation. In case of type 2 respiratory failure, in type 1 respiratory failure, there is hypoxemia. Though these are the causes and site affected. So, respiratory acidosis, what all causes? Respiratory center damage. It can be caused by morphines, benzodiazepines, stroke, that is decreased blood supply to the respiratory centers. Next, the spinal cord damage can also cause the respiratory effort decrease at the level of C3 or above, that is fractures and polio and amyotrophic lateral sclerosis. Next comes the phrenic nerve damage. It can be neuropathy like Guillain-Barré syndrome. Next comes the neuromuscular disorders like presynaptic Lambert-Eaton syndrome and postsynaptic is myasthenia gravis. Muscle damage is diaphragmatic muscle damage like Duchenne muscular dystrophies in myopathies, chest wall stiffness in kyphoscoliosis, obesity, chronic damage of small airways in chronic bronchitis. So these are the causes of respiratory acidosis due to hypoventilation. Next, the respiratory alkalosis. So here comes respiratory alkalosis. In respiratory alkalosis, the mechanism is just opposite to acidosis. Here it is hyperventilation, that is carbon dioxide is washed out. So the causes can be central or peripheral. Drugs like progesterone, especially in pregnancy, there is increased respiratory rate as well as there will be increased tidal volume. Salicylic drugs, infections like meningitis, encephalitis. And importantly, there is anxiety is very important. Next, lungs compensatory mechanism in case of peripherally pneumothorax, alveolar edema, pneumonia, ARDS. See, if these are two lungs. If one lung is causing these all pneumothorax, alveolar edema, pneumonia, ARDS, this lung will compensate and hyperventilate, leading to respiratory alkalosis. Next, the systemic cytokines like interleukin 1, IL-6, this stimulate respiratory centers, especially in sepsis and fever. Next, we will stepwise we will analyze the ABG. First one, we can easily at one point of view we can find out what is the wrong with the pH. First one is type 1 diabetic patient with poor compliance to insulin. Probably he will be having diabetic ketoacidosis. We told that it's HACMA. Why? Because of acetate, which is a anion, which is a unmeasured anion, and the bicarbonate released will bind with HCO3 minus and form acidosis. So that is high anion cap metabolic acidosis. Next is chronic bronchitis. There is hypoventilation, which causes respiratory acidosis. Severe vomiting. There is dose of H plus from the body. So H plus can be replaced if there is chloride repletion. In case of chloride responsive respiratory alkalosis, there is metabolic alkalosis. Next is diarrhea, loss of bicarbonate from the body. So what does it mean? It means that it is acidosis, metabolic acidosis. Step 2, ABG, you look at the pH. When you look at the pH, you look for the analysis. That is 7.4 is the normal pH. If it is less than 7.4 is acidosis. If it is more than 7.4 is alkalosis. For example, 7.36 is acidosis, 7.42 is alkalosis, 7.4 is either no disorder or mixed disorder. Next, step 3, metabolic.